Hello, ladies and gentlemen. This will be a talk on breast cancer, and this talk is supposed to go hand in hand with another talk that I did on breast masses and cancer, which is more a diagnostic and algorithmic approach to how you may approach test questions. This is sort of your overview of breast cancer. We're going to talk about epidemiology and risk factors, as well as the difference between uh, ductal carcinoma and lobular carcinoma, which is important. I didn't really touch on that because ductal and lobular, you don't really have a whole lot of difference in management. So I can't recommend which video you should watch first. They're both important, so I would recommend watching both, but you may go back and forth between the two. Uh, this one though is going to be important for your general concept of what breast cancer is and its implications. Now I'm going to put up another video that gives you pictures of the breast, so that you'll want to watch as well. But the reason I'm not including it on this one is because YouTube likes to, they kind of get weird about pictures of breasts and genitalia, even when it's in an educational context. And so I don't want them to strike this video and say you got to be 18 to watch it. So that's why I'm including it in a separate video. Now, I did a video on breast cancer about 7 years ago. So this is just kind of an update to that video that I gave, and I'm also going to try to keep it a little more concise for you too. If you haven't had the opportunity yet, please consider subscribing to my Patreon. I got the link below in the description of the video, or you can click on the I button right up here. If you can consider chipping in $1 a month, a little bit goes a long way to help offset the cost of these videos. So I appreciate your consideration. All right, so we're going to talk here about breast cancer. There are a number of different masses that you can have in the breast that are benign. Here we're talking about malignancies. Breast cancer is the most common non-skin cancer in women, and it is the second leading cancer killer among women, second to the lung. Remember that lung cancer is the number one cancer killer of both men and women, and the breast cancer is number 2 in women. Over 276,000 cases were reported in 2020, and that's up from 230,000 cases in 2013. So that is some significant growth, and that's not just because people have more risk factors. It's because we're getting better and better at diagnosing this at earlier stages or earlier on in the development of breast cancer. My mom is a breast cancer survivor. She was diagnosed by computerized mammography, 3D mammography, and the tumor was only 4 millimeters. That's like the size of a popcorn seed. So very, very small, and we're getting better at diagnosing this, and it's really a great thing because more and more breast cancers are being diagnosed at stage 1, which is very, very treatable, great prognosis, and so that's what's behind the higher number of cases that we see each year. Now, obesity is a risk factor, as we're going to see, and obesity is becoming more prevalent, and so that's playing a role as well. But really, what's driving this is that we're getting better at detecting this earlier. 1 in 8 women will be diagnosed with breast cancer in her life, and that number is going up. Risk factors, here they are. Being female, being a little bit older, in your 40s, 50s, and 60s. The median age is in the mid-50s. Personal or family history, usually associated with a BRCA mutation. Nulliparity, obesity, hypertension, diabetes, generally associated with obesity. And then there is an increased incidence in the Ashkenazi Jewish population. There are some associations, really lifetime estrogen exposure, so earlier menarche, later menopause. The use of contraceptives as a risk factor is debatable. So the thought is that the more estrogen you're exposed to, the more likely you are to develop breast cancer. And a lot of contraceptives, the combined contraceptives, they have an estrogen component. So, but this is really debatable. So that's why I included this last. Now, if you have a primary relative with breast cancer, your risk goes up. But notice here that the risk is higher if the breast cancer was bilateral, And the risk is higher if the relative developed it premenopausally. And the reason that the risk is higher is because both of those, bilateral and premenopausal, are associated with a genetic cause as opposed to a sporadic case. The genetics include the BRCA mutations. Testing is available for that. Any patient who's premenopausal, who has breast cancer, or who has bilateral breast cancer should be tested for the BRCA mutation. And then there's Li-Fraumeni syndrome. That's a mutation of P53, the cancer-causing gene. This is associated with cancers of the breast, brain, and adrenals, as well as soft tissue sarcoma. So look for family history of cancer. Anytime you're working up a cancer patient, you should always ask their family history of cancer, because you want to sniff these familial cancer syndromes out. Okay, so breast cancer should be suspected in any woman with a breast mass. So any woman who comes to you saying, I feel this mass in my breast, you need to consider breast cancer, you need to do a workup. I talk about that in greater detail in the other video, the algorithm of how to work up a breast mass. Different features that you would look for that would make you suspect breast cancer include an ill-defined mass, as opposed to feeling something that's very obviously round, well-shaped. If the mass is fixed, so when you feel a breast mass, if it kind of rolls around your finger, that's not as suspicious for breast cancer as if the mass is really just fixed in place. And if it's attached to the chest wall, if it's deeper, that's more concerning as well. Overlying skin changes, I'll show you some pictures of that in the next video. Nipple retraction, and then axillary lymphadenopathy. Now, axillary lymphadenopathy is difficult to appreciate in heavier women. So for those women, we may do an axillary ultrasound, and usually that's going to be done after the confirmation of breast cancer, but prior to surgery. But if you've got a patient who's thinner and they've got a breast mass, and then they also have, axillary lymphadenopathy, they've got a mass in their axilla, that is very suspicious for breast cancer, and breast cancer at a higher stage. Now, when you suspect breast cancer, the very first thing that you should do is imaging. Now, what imaging you get depends on the age of the patient. The rule of thumb is if the patient's over 30, you get a mammogram. If they're under 30, you get an ultrasound. But it really just depends on the density of the breast. You could have a woman in her 30s who's got really dense breasts. You may want to get an ultrasound in that case. And the reason is because mammogram is really just like an x-ray. And the ducts and the lobules really obscure the breast. And so it's really hard to see masses when you've got all those structures in the way. So in those cases, you want to get an ultrasound. Suspicious lesions should be biopsied. What do we mean by suspicious lesions? Well, if you get a mammogram and it says architectural distortion, that's suspicious. If you get an ultrasound and it says a complex cyst or a solid mass, that's suspicious. So you would want to get a biopsy for that. We're going to talk about non-invasive breast cancers first. Those are your carcinomas in situ. This is a schematic of the breast. So the functional unit of the breast is the lobule, which makes the milk, secretes the milk, and then it comes down through the ducts and then ultimately through the nipples. You can have breast malignancy arising in two different places. It can be in the lobules or it can be in the ducts. If it arises in the lobules, it's called lobular carcinoma. If it arises in the ducts, it's called ductal carcinoma. If it's confined to the breast tissue, to the lobules or to the ducts, then it's considered in situ. So lobular carcinoma in situ or ductal carcinoma in situ. If it invades the basement membrane, then it's considered infiltrative. So infiltrative ductal carcinoma or infiltrative lobular carcinoma. And it's the ductal carcinomas which are more common, but the lobular carcinomas are more likely to be bilateral. So first, ductal carcinoma in situ. This is carcinoma confined to the ductal tissue without invasion of the basement membrane. The treatment here is lumpectomy. So we do lumpectomy. with or without radiation, but typically it's just lumpectomy. You take the carcinoma out and you're done. Now, some women may want a mastectomy, but that is not necessary. Chemotherapy is not necessary for any in situ carcinoma. Chemotherapy is only for infiltrative cancer. There is a risk of recurrence, so if you just do a lumpectomy, the risk of recurrence is about 25%. So you want to monitor these patients very closely because any carcinoma in situ can and will go on to become infiltrative cancer. So you've got to monitor these women closely. They're at very high risk. If you do a lumpectomy plus radiation, the risk of recurrence is lower. It's about 8%. And if you do a mastectomy, then it's less than 1% for obvious reasons. Lobular carcinoma is basically the same management and treatment. The only difference is that this is more likely to show up bilaterally. So if you have lobular carcinoma or lobular carcinoma in situ in one breast, you're at a higher risk of having it in the other breast. So for that reason, these patients may want to consider bilateral mastectomy. Obviously, you can't do a lumpectomy in the unaffected breast because there's no lump there. So these women may want to consider prophylactic bilateral mastectomy. All right, now moving on to the invasive cancers. Invasive ductal carcinoma is the most common breast cancer. So if you've got a woman who says, I have breast cancer, it's most likely she had infiltrating ductal carcinoma. And this accounts for about 70% of breast cancer diagnoses. Now, the initial workup may include these things, but these things are more important to get if you suspect systemic metastatic disease. This is not necessarily part of your workup for just any patient with breast cancer, especially if you have reason to believe that it's localized. The treatment is dual, it's surgical and medical. Usually, you'll go about treating this surgically first. So you can do this two ways. You can get a lumpectomy with a sentinel node biopsy, and then that will be followed by radiation. You can also do a mastectomy. That you also need to get a sentinel node biopsy. That does not need to be followed by radiation. If there is invasion of the chest wall, then you need to do a radical mastectomy. Now, in some cases, if the tumor is really large, then you may need to do a neoadjuvant chemotherapy, and that's to shrink it down and make the surgery easier. Chemotherapy is done if there is spread to nodes or if there's distant metastases or if it's HER2 positive, you'll do chemotherapy. And then hormone therapy long term up to 10 years if the tumor is hormone receptor positive. And what would you use for hormone therapy? You would use estrogen inhibitors, selective estrogen receptor modulators like tamoxifen if the patient is premenopausal. If they are postmenopausal, you use aromatase inhibitors like anastrozole and letrozole. All right, now moving on to the lobular carcinoma. Really, it's the same management. Just bear in mind that there's a strong tendency towards bilaterality. So if the patient goes for mastectomy, you may want to advise them that they might as well get both breasts taken off because their risk of developing cancer in the other breast is almost 1 in 3. So that's something that they'll want to consider, but otherwise the management is the same. We already kind of talked about the treatment strategies, and I go into this in the other video, but I just want to reiterate here. The patient has the choice as to whether they want to get a lumpectomy or a mastectomy in most cases. So if you go ahead with a lumpectomy, you need to remove the tumor with clear margins. That's very important. So when the lumpectomy is done, it's sent to the surgical pathologist and they'll look to make sure that there's clear margins, because if you don't have clear margins, it means you didn't get all the tumor. You're also going to get a sentinel node biopsy, and again, that pertains both to the lumpectomy and mastectomy. Sentinel node biopsy, the idea there is that you're injecting a dye into the lymphatics, and that dye will go to 1, 2, 3, 4 lymph nodes first. You've got tons of lymph nodes down there. And so you don't want to have to take them all out if you don't have to. So the idea is that wherever that dye goes, that would be the first node that the cancer would go if it spread to the nodes. So you'll biopsy just those nodes. And if those nodes are negative, then you don't need to do anything more. What you're avoiding here is an axillary dissection. An axillary dissection is problematic because when you remove lymph nodes, you're increasing the resistance of the lymphatic system distal. And the problem with that is that you can get lymphedema, and we want to avoid that. So if the sentinel node is positive, then you may proceed to an axillary dissection, but if it's negative, you don't need to go any further. And also knowing whether or not the cancer has spread to the lymph nodes is important for staging, because remember we use the TNM system for staging breast cancer. We don't go based on the grade. The modified radical mastectomy is removal of breast tissue and the nipple, and then you may do a dissection of the axillary lymph nodes, and then breast reconstruction as elected. Radiation is recommended for patients that are getting a lumpectomy as well as high risk patients. And then this is an important fact here that you'll want your patients to know. Regardless of whether they choose a lumpectomy or a mastectomy, the survival is the same. The benefit to a mastectomy is that they have a lower likelihood of recurrence and they don't have to go through this again. And for a lot of patients, just being diagnosed with breast cancer is traumatic enough. A lot of some patients just want the thing off and they don't ever want to have to go through it again. And so a mastectomy reduces your risk of recurrence, but it does not change the survival outcome. And also, mastectomy is a much more invasive surgery and a longer recovery time. So there's pros and cons. Chemotherapy is indicated for all patients with positive lymph nodes, all patients who have HER2 positive cancers, irrespective of their lymph node status, and for patients with metastasis. Hormonal therapy is indicated for everyone if they are estrogen receptor positive. The HER2 new oncogene is revolutionary. Since we discovered it in the early 2000s and developed treatment, Herceptin or trastuzumab came out on the market in 2006, and it's really revolutionized treatment for patients with HER2 positive cancers. HER2 positive cancers used to come with just a really dismal prognosis, and now it's almost gotten to the point where HER2 positive cancers have a similar prognosis to the HER2 negative cancers. However, HER2 positive cancers do still tend to be more aggressive and can spread faster. Intensive follow-up, very, very important for any patient with breast cancer or who has had breast cancer. So finally, we'll go into some of the rare cancers and some special considerations. So we're just going to touch on these briefly because they're uncommon and they don't tend to come up on exams too often. Inflammatory breast cancer, this is an aggressive variant, 1 to 4%, usually shows up with advanced signs, skin symptoms, and distant metastasis. Surgery is not effective, so the treatment is just chemotherapy, and the prognosis tends to be pretty poor. Infiltrating papillary carcinoma, I want you to associate this with bloody nipple discharge. So you've got a patient coming in with bloody nipple discharge, or you have a patient on your exam who has pink discharge from the nipple. You need to think of infiltrating papillary carcinoma. It's very rare, but it does come up on exams. Paget's disease of the breast is an eczematous dermatitis of the nipple. This usually signals an underlying breast cancer. So the next thing to do if you've got eczema on the nipple is to get mammography or ultrasound, depending on the age, and work the patient up as usual. Some final notes, male breast cancer is possible, but they are outnumbered by females by about 100 to 150 to 1. The treatment is the exact same. Men with Klinefelter syndrome, as well as men who have higher estrogen levels, usually due to liver failure, they are at increased risk. Breast cancer during pregnancy is worked up the exact same way. There are just a few differences in treatment. Radiation is never given during pregnancy, and chemotherapy is not given during the first trimester. Preoperative radiation and chemo is often performed in patients with very large breast cancers. Remember, that's the neoadjuvant chemotherapy, and that's done because it makes the surgery a lot easier. And then I want to end on a positive note. Stage 1 breast cancer with treatment, the survival is approaching 100%. So that's incredible. We've really come a long way. So, when you buy those, yogurt lids with the pink tops and you're putting money towards breast cancer research, you are helping very much in improving the prospects of future women with breast cancer. So we need to keep up this good work. And that's all I've got for you. Again, I'm going to do a video showing pictures, so stay tuned for that. Go ahead and watch that if you want to, and I'll see you then.